right, well this slide probably, this PowerPoint probably has a little bit too much information. Some of it you've already heard, and then it goes into details about passive and active reabsorption, active secretion, probably some pictures of pumps, blah, 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 blah. Too much information, but I want to be sure that I don't miss anything. So I'll tell you if I see a slide that's got too much stuff going on. Okay, hopefully you grasp the part that filtrate is passive. Secretion is active. Reabsorption can be both. Reabsorption is moving something from the filtrate back into the blood. So 99% of everything that got dumped into the filtrate is going to be reabsorbed, especially water. That direction. Yeah, who cares? It could either go around the cells or through the cells. Like that. So the most abundant cation in the filtrate is going to be sodium. And he can be primary or primary or secondarily pumped back into the blood. So it might be that primary sodium-potassium pump, or if you remember from AMP1, sometimes there's secondary transport where we're almost getting energy from the sodium pump moving on to the next pump. So we're going to have co-transportation. Again, probably too much information. Who cares? Water often is osmosis, so just actively going from high concentration to low concentration, and often, in this case, from aquaporins. In the proximal convoluted tubule, we always have aquaporins. Depending on hormones determines if there's going to be more aquaporins put inside the collecting ducts or the distal convoluted tubule. This doesn't say that. So solutes sometimes are going to move from an area of high concentration to low concentration from those, again, from AMP1, those constantly moving leak, opening and closing channels, or leak channels. Too much information. Okay, now sometimes things can hit too high of a level where it gets to the point that cells can't keep up, especially if we're talking about moving through the cells. So not sneaking between cells, but going through the cells. And glucose is an excellent example of this. So you should maintain a decent level of sugar in your blood. When you have a level and it goes through the filtration system, your proximal convoluted tubules should pick it back up. But sometimes it's such a high amount, it's overload, so you're going to end up not reabsorbing it. So that's called a transport maximum. I have hit, you have way too much of that. I can't possibly recapture enough of that and put it back in the blood. Urinalysis is a great way to diagnose diabetes. All right, site of reabsorption, most of it, proximal convoluted tubule. Enough said. Nephron loop, I've already said this. At the descending loop, water can be reabsorbed. Solutes can't. At the ascending loop, solutes get reabsorbed. Water can't. Distal convoluted tubule is where the majority of hormonal regulation happens, so antidiuretic hormone and aldosterone, and so I've already said this. Aldosterone's like salt. So if it's deciding that our sodium balance is out, we need some more sodium in the blood, aldosterone's going to come out. Water's going to follow sodium. Too much information. But remember, wherever we have sodium going in, we're going to have potassium going out. So maybe the body recognizes, something going on with the potassium. Okay, yeah. Oh, this is one I haven't mentioned yet. I mean, I have in the past, but not now. Atrial natriuretic peptide. This guy recognizes it's in your atrium. He's the guy that's recognizing your blood pressure is too high. The atrium is getting pounded. So ANP is trying to decrease the amount of sodium that gets reabsorbed so you can urinate some of that sodium out. Water's going to follow sodium, so therefore you're decreasing the volume of blood in the vessels because you're getting rid of water. Water's in the blood, getting rid of it, and so therefore you're decreasing your blood pressure. And then here's another guy that I haven't mentioned that much either, parathyroid hormone. So in AMP1, we talk about how he tells the osteoclast to shave on the bone to get some more calcium in the blood. But here's another place that he acts on. If he's deciding that you are low on calcium, he doesn't just tell the osteoclast to get busy. He also asks the distal convoluted tubule to reabsorb more calcium. Don't let that go out in the urine. Get that calcium out of the filtrate and get it back in the blood. So he does that too. Pictures, cool pictures, study that. Cool pictures, cool pictures. Okay, tubular secretion is an active process where we're removing stuff from the blood and shoving it back into the filtrate. This can happen at the collecting ducts or the proximal convoluted tubule. So why do we need to do that? Just like in lab, we talked about how we used the penicillin and broke it down into bits. We got to get it into, we've used it, it's done. Let's get rid of the metabolites. Anything synthetic. Things, nitrogenous waste. Let's get rid of it. Now, I know in lab, it talked about urea just got filtered and then that's it. It's actually more complicated than that, and I'm pretty sure I have that in a slide in a minute. Getting rid of excess potassium, we're going to do that. Controlling pH. Do we have too much, or is our blood too acidic? We've got to get rid of some hydrogen ions. You get the idea. Here's a picture. Too much information on this slide, going back to that whole osmolality. We need to stay isotonic. We need to stay roughly around 300 milliosmoles. That's what we're supposed to be. So our kidneys are in charge of doing that. If we're really dehydrated, so we're not taking in enough water, then we're going to save as much water as possible, so you're not going to be producing a lot of urine. This happens at those juxtaglomerular nephrons, the ones that go deep down, where instead of talking about the peritubular capillaries, we have the vasa recta. This is where this happens. So the majority of the concentration, because you're not getting enough water in, we need to conserve as much water as possible. It happens here. Sorry, again, this slide has too much information, but what happens is those loops are so close to each other that their reabsorptions affect each other. So there's a lot of exchanging going on in these depths between sodium and water. This is just showing at the deep juxtaglomerular nephrons how salty things can get in the depths. And this is all about concentrating urine. Do I need to save water? If I need to save water, then I need to concentrate my urine. That's these guys, the 15% doing this job. What's a diuretic? The job of a diuretic is to make you urinate more. How does he? There's different ways that it can do it. So there's different kinds of drugs. ADH inhibitors, that's how alcohol works. So you drink, you need to pee more. It's because we're inhibiting the release of anti-diuretic hormone. This is the hangover thing. You lost too much water. If you lose too much water, you get a headache because you're dehydrated. Some things prevent the reabsorption of water, like caffeine. Some drugs for hypertension can do this too. Osmotic diuretics. So like sugar is attracting water too. So if you are an uncontrolled diabetic, then you're spilling, you've hit max, you've hit transport max, transcellular reabsorption. You can't reabsorb it all, so you're spilling glucose. Well, glucose is going to attract water. There's going to be a pull, an osmotic pull, because of the glucose. Because it's like, hey, you don't have enough water. You have so much sugar, you're not watery enough. So the water's going to follow it. So in other words, diabetics urinate a lot. One of the symptoms for diagnosis. So urinalysis, wow, I mean, so important of a test. And, you know, sometimes with checkups, instead of doing blood work, they just do a urinalysis. And you can get a lot of information from this. Perfectly, though, to know what's going on with kidneys, you need to do both. You compare the urine based on blood values and vice versa. Oh, I really don't want to get into this, but using clearances of often creatinine, they're going to see what your glomerular filtration rate is. So if it gets too low, then we've got some problems going on with your glomerulus. So renal clearance is essentially used to see if you're doing a good job getting rid of substances. And there's actually one called inulin, which that test is actually way too expensive to get that. Inulin does not get secreted or absorbed, so what goes in should come back out. Now they're using creatinine, but I tell you there's a problem with that. Is if you're a really well-muscled person, it's going to make your GFR look off. That's also true with greyhounds. So greyhounds usually have an off GFR, but it's not that there's anything wrong with them. So there's going to be individual differences when you use creatinine clearance. So keep that in mind if you have somebody that's getting their kidneys checked out. Okay, chronic renal disease, that means that your GFR has been less than 60 mils per minute for 3 months. Okay, so what's going to happen if you're not filtering, then you're going to build up these things that you're supposed to be getting rid of in your blood. So urea, uric acid, and creatinine start to get too high in your blood because you're not PPing them out. Kidney failure causes uremia or acetemia, which means you've got too much urea in your blood. You can actually smell when somebody is azotemic. It has this odd smell. It's not a good smell. It's not a describable smell either. When your kidneys aren't working very good, if your GFR is less than 15 mils a minute and you are in failure, now again, this could be acute or chronic. Acute is a lot of times fixable, not all the time. Chronic, you're going to go on to dialysis. These people just don't feel good. They're tired, they're nauseous, maybe they're cranky. So urine should be full of urea, uric acid, and creatinine. That's normal. We want that. That's its job. But there's other things that we look for in a urinalysis that are much more common than kidney failure. We're going to look for sugar, for diabetes, proteins. So you can spill proteins in your urine. It is not normal, but there are some things that can cause it. So that person that is extreme in exercise, you might end up finding some proteins in their urine. One thing that I noticed that doesn't get mentioned in here is if there is just a slight little leak of semen into the urine, that's all protein type materials. So there might be some in there. I mean, you shouldn't, but if there was a little bit in there, then that could happen. Most of the time, it's disease. Ketones are usually going to happen with starvation and diabetes mellitus that's not controlled. Hemoglobin, well, that can happen if there's something breaking up your red blood cells, so nothing good. bile. Is there something going on with your liver or your gallbladder? Straight erythrocytes, so I'm not talking about hemoglobin, but blood. That's usually going to be infection, bleeding, cancer, and then, of course, white blood cells. It's going to be urinary tract infection, either bladder or kidney. And then I'm going to tell you something. Those sticks that tell you that there's leukocytes, so just a plain old peeing on a stick, don't trust those. You need to do a cytology. Really important. You should prove it. If somebody gets a messed up urinalysis, there's no blood, pH is normal, everything else is normal, and it shows that there's leukocytes, you should prove it. And do a cytology and send it off to the lab if you need to. If you're not comfortable with cytology, it's really pretty easy to see a white blood cell, though. So do it. Impress everybody. Urine should be clear. Some shade of yellow. It might be really, really light yellow. It might be really dark yellow. If it's very, very concentrated, that's what happens with concentrated urine. It gets more and more deep yellow. Abnormal colors would be brown, grays, pinks, of course, if there's blood in it. Okay, urine initially, it has a scent, but that stinky scent of like Bourbon Street urine, that's because bacteria are metabolizing the urea into ammonia. So once that urine sits out for a little bit, bacteria start to break down the urea, and the byproduct is ammonia. And of course, you know, certain things can change the smell of urine. Asparagus is a biggie. If you like asparagus and you've eaten it and then you've urinated, you've noticed something different. Temporary. Urine should be slightly acidic. When you're on a well, I shouldn't say regular diet, just maybe an American diet, proteins and breads, and of course some veggies, then your pH might be a little bit lower. If you're a vegan or a vegetarian, you're throwing up too much, your urine can be alkalotic. And that's why I keep on talking about you are more prone to a bladder infection when you are a vegan because your pH is too high. Bacteria don't like to live in acidic pH, and that's why let's say you can't get to the doctor, it's Saturday night, you notice you don't feel good because a urinary tract infection is miserable. You take cranberry tablets or eat cranberry straight because it really decreases the pH of your urine. It makes it more acidic. So a temporary fix to the bacteria going through multiplication. You're going to slow down the bacteria from multiplying if you make your urine more acidic. Urine pH range, specific gravity range is going to be from 1.001 to 1.035. Past 1.035, that's getting a little too concentrated. 1 or less is going to be too unconcentrated. Something's up. So specific gravity of water is 1. Ureters are also retroperitoneal. They're going to go to the bladder, which is hypoperitoneal. Actually has valves. It's pretty cool. I've seen the valves working on an ultrasound that I did once, and I don't do ultrasound very often, so for me to see it was pretty cool. There is smooth muscle in the ureter to constantly move the urine from the kidneys to the bladder, so we're not counting on gravity. You know, you lay down and take a nap or you go to sleep at night, you still need the urine to move from your kidneys to your bladder. So you have smooth muscle in there that's helping it. And of course, we're going to have a epithelial layer, that transitional epithelium that I taught you about in AMP1. And then the outer layer, adventitia. It's not called serosa. Beautiful pictures. Stones. So kidney stones are called calculi, and if it's in the kidney, then it's going to be renal calculi. You can have them stuck actually inside the renal pelvis, or they can get lodged in the ureter. That's very painful. So you're passing a kidney stone, very, very painful, because you can appreciate that's a pretty skinny tube, and now we're stretching it out. Most of the time they get through without any sort of intervention, but sometimes you can break it up with sound waves. That's called lithotripsy. Okay, there's an area where the bladder is tapering down, and that is called the trigone. This area is where bladder infections have the tendency to settle out. Layers, very similar to the urine. We're going to have an epithelium, a smooth muscle, and then we're going to have a adventitia on the outside. That muscular layer has a very thick, smooth muscle that actually is layered. It's called the detrusor muscle. How much urine can we hold? Well, it can hold 500 mils. It actually can hold a lot more, and you are very, very miserable if you make it go past 500. 1 liter, you're getting to the point that you're trying to kill the nerve endings in your bladder. So you can actually, if you hold, of course, this would be something that would be, pathologic. Maybe you physically can't urinate, like post-anesthesia or a blockage. But what's going to end up happening is you start causing so much pressure. You have pressure that can potentially rupture your bladder, or the pressures can actually push open. There's valves, like I said, that are going from the ureter into the bladder. Push those open from pressure and start putting pressure on your renal pelvis, which is going to put pressure eventually on the tissues of your kidney, the interstitium of your kidney, and start to kill your kidney. So, must be careful. Again, pathologically. If it's, let's say that it's because of post-anesthesia. So an anesthesia thing has made you unable to urinate. They're going to pass a urinary catheter to prevent that kind of stuff. It looks kind of like the stomach too. It gets these little folds on the inside of the bladder when it's empty. Cool picture. Urethra. You have an internal urethral sphincter that you are not in charge of. You have an external urethral sphincter that you are in charge of. When it's time to urinate, they both open. Female urethra is shorter. It's also, compared to how men's urethra is kind of way out there on the outside world, the women's urethra is really close to the anus. So bladder infections are more common in women from bacteria moving anteriorly towards the orifice. Male urethra, not just the part of the urinary system, also part of the reproductive system, and we've done this already. You have the part that's the part that's passing through the prostate is prostatic urethra, and then the part that is going through the penis is called the spongy urethra. Honestly, I wouldn't quiz you on that, but Dr. Johnson might. If it's in the lab book, it's fair game. Pictures. There's the trigone. I wish I had a pointer. And there's actually, here's also a good picture of the bulbourethral glands. They're not labeled, but notice there's one on the left and the right at the base of the penis. So trigone is that area where we're more prone to bladder infections, and the top part of the triangle is where the ureters are dumping in. Cool picture. Okay, urinary tract infections. A lot of times it's just bad luck, migration of things making it into the urethral orifice. And females, again, are more prone to that just because the urethra empties so close to the anus. So your mama probably taught you wipe backwards, not forward. Sexual intercourse is another way that this can happen, especially spermicides have a tendency to increase the chance of this happening. Very uncomfortable. You can get inflammation of the urethra from any of those sexual transmitted diseases that I've mentioned. The term cystitis sure is a good fill-in-the-blank question, because if you're a nurse and you're filling out a record, you're not going to put bladder infection. You're going to put cystitis. So I would know that for a fill-in-the-blank question. Painful urination is called dysuria. You feel like you need to go more because there's all this inflammation in the bladder. So since it's inflamed, it's tickling those nerves and you think you need to go, when in fact you don't. If you get an infection in your kidneys, you actually might get back pain, because think about where they're located. So some people will think that they're having back problems before they recognize that it's actually truly a kidney problem. Thank goodness for antibiotics. Another term for urinating is micturition. So that detrusor muscle that I mentioned in the bladder, that guy is going to contract, which is going to open the internal urethral sphincter, which is then you are in charge of the next part. Is this a good time to go? I guess if this is a good time to go, then I'm going to open my external urethral sphincter. Babies, we haven't really gotten those axons to that area to help us understand exactly how to do that, but we're going to learn, and by the age of 2 or 3, you should be in control of all that. Urinary incontinence. A lot of times this is just from weakened pelvis muscles, especially if you've had many children. Well, I guess you don't have to have many children, but this would just be from pressure. All those pelvic muscles are weaker, and so things like just coughing can actually make a urine leak happen. And if it's overflow incontinence, so what happens with that? That would be like if you have paralysis of the spinal cord. So you can't go, or like if your doctor didn't catch that you have anesthesia-related inability to urinate, the bladder gets so full, it just starts to dribble out. But in the meantime, you're killing neurons, so it can become a permanent problem if that doctor doesn't catch that. Same thing with paralysis. If you're paralyzed in the right spot, it depends on where you're paralyzed at, but if you're paralyzed in the right spot, then it changes how that bladder behaves, and then you can get overfull bladder and problems, damages to the neuron. Oh, I've already kind of mentioned this. Well, actually, I mentioned the general anesthesia. I didn't mention sometimes the prostate gets enlarged, so just benign prostatic hypertrophy, and so you don't empty enough. If you don't empty enough, then you have to go to the bathroom more often. If it gets bad enough, it can squeeze off that prostatic urethra altogether. I would think that would be pretty rare, and the treatment would be catheterization. Especially after that general anesthesia, you just pass the catheter. Abnormalities that can happen, your kidneys could be mal-shaped. Sometimes the urethral orifice isn't coming out at the end of the penis. Sometimes it's on the ventral surface, but that would be something that you would correct surgically, and that would be called hypospadia, not an uncommon birth defect at all. Polycystic kidney disease means that your kidneys are full of cysts, which means you're missing some nephrons. It's not common, but it can be a very serious thing and might eventually require a kidney transplant. Persians in the animal world, we'll start to look for that in Persian cats and King Charles Spaniels. Alas, as we get older, our kidneys start to shrink. They're just not working as good as they used to. Are y'all tired of me saying that? By the time of age 80, your glomerular filtration rate's probably been cut in half. And this is actually what took, in the end, took Bob Neighbor's life. He was 85. He's the writer, one of the original writers of your lab book. and Superman. And if you're in AMP1 with me, you could have gotten a glimpse of him on some of my videos, especially the nervous system video. But usually when this happens to a person, it's not a surprise. This is a long time coming. So as far as Bob is concerned, they told him he'd have a year to live, and I think he lived another 3 or 4. So he did good.